All right, class. This is going to be my first voiceover PowerPoint for you. I know you've heard a lot from Professor Fulbaum, but you're going to hear a little bit about heart failure from me. So I want you guys, as you're listening to the PowerPoint, I'm going to do them in segments so that they're only 10 to 15-minute segments for you to listen to. I want to focus first on the pathophysiology of heart failure. There's several different types of heart failure. There's systolic, diastolic, left-sided, right-sided, both-sided, and there's a couple other things you need to know. But I want to just kind of explain the pathophysiology leading up to the failure part of the heart or the pump not working. So I want you to open your books electronically or if you have them in hand to chapter 35 out of the Lewis book so that you can kind of highlight and go along with. If there's anything that I go over too quickly, it will give you an opportunity to highlight it or tag it in your book or in your reading and go back and read a little bit more about it. So I hope you enjoy and I hope you learn lots. I'll be asking questions throughout the voiceover. So I want you to really try to answer those to yourself. And if you're not able to, bring questions to class that we can go over to help increase your understanding as far as the PowerPoint content and concepts of heart failure. Before we can really get into some of the pathophysiology of heart failure, I think it's important that we first discuss the function and the purpose of the heart and the different chambers of the heart so that we can kind of have a better understanding. So this should be review for you as far as the blood flow. So all of the venous blood is coming into the right atrium of the heart. And I suggest you guys write this or draw this out. It just kind of helps helps you to kind of remember and review it. So the venous blood's coming in through the right atrium, where the right atrium contracts and pushes the blood into the right ventricle. Then from the right ventricle, the blood gets pushed through the pulmonary artery in through the lungs for gas exchange and oxygenation, where it then goes into the left atrium of the heart, oxygenated from the left atrium into the left ventricle. And then the left ventricle is the biggest part of the heart, gives the best contraction because it's responsible for pushing that blood throughout the entire body. So for this slide here, it kind of is going over that description a little bit. An abnormal condition involving impaired cardiac pumping and or filling. So if it's not effectively pumping, then it's not effectively ejecting or getting rid of the blood there, which means it will affect the refilling process of the heart because there may be residual blood left. It's just not able to meet the demands of the body. So if you kind of put that into perspective, you can kind of start to understand heart failure means pump failure. So the pumping part, there's something wrong, whether it be the blood, the right side of the heart or the left side of the heart, or if it's in systole or diastole. It's not properly functioning, it's not properly contracting to the point where it's not meeting the cardiac output needs and the metabolic needs of the body. Okay, continuing on, talking about the metabolic needs of the body. The heart failure can be characterized by these items here. So I just want to talk a little bit about each of those. Usually there's a ventricular dysfunction, whether it's right-sided or left-sided, which could eventually mean the electrical impulses and the actual rhythm of the heart can be affected by it. These patients have reduced exercise tolerance, and I think that should kind of be self-explanatory. So the heart's not able to meet the demands of the body, the metabolic demands. So, these patients get tired really easily. They have a difficult time, with almost any activity, let alone exercise. It leads to diminished quality of life and a shortened life expectancy. And remember, the cardiac muscle is really important. We can't live without a functioning heart. These patients, depending on how sick, when we talk least invasive, least expensive, of course, the treatment starts off with reducing the, any of the modifiable risk factors to correct, or to even start medications that help with contractility or help remove extra fluid that's hurting the heart. So I hope that kind of makes sense, that these characteristics of heart failure should not be very surprising for a patient if you think about the concept of the heart and what's not happening for the patient. Heart failure affects about 5 million people in the United States. The most common reason for hospitalizations in adults that are over the age of 65 years old, and it's also a common readmission reason. So a lot of the goals for healthcare providers in a hospital setting is to prevent readmission of patients who are suffering from exacerbations of heart failure, which means this involves a lot of patient compliance, and it involves a lot of education to these patients to truly understand their disease process and how to manage it at home carefully and safely, so that they aren't going back to the hospital very often. We're going to go into the etiology and the pathophysiology of heart failure, so it will kind of give you a clear picture as to why there's so many people in the United States suffering from this disease. Some of the primary risk factors to heart failure include coronary artery disease and advancing age. Coronary artery disease, along with these contributing risk factors, put the patient at a much higher risk, or much likelier, they're much more likely to develop heart failure. Hypertension is the major contributing factor. And it's not just hypertension, but it's often uncontrolled hypertension, excuse me, mismanaged hypertension, or mistreated hypertension. This does increase heart failure by 3 times, the risk of heart failure by 3 times. Also, with advancing age, I mean, if you think, it's referred to as pump failure. And if you think anatomically of the body and the work of the heart, and as age progresses and kind of just almost a wear and tear of that pump, if the patient has these other risk factors, or those other contributing risk factors, that makes the patient more likely just with advancing age as well. Diabetes, tobacco use, obesity, and high serum cholesterol levels, in addition to coronary artery disease, advancing age, and hypertension. All of these have to do with vascular issues. Especially with diabetes, there's a lot of micro and macrovascular complications that are associated with diabetes, and you will get into that a little bit more in a few weeks as we cover diabetes. Tobacco use, related to poor perfusion, vasoconstriction, obesity, the things that lead to obesity, usually the sedentary lifestyle or the eating habits, and some of those things, and the high serum cholesterol. All of these lead to or contribute to or make the patient at higher risk for developing heart failure. Okay, so we're going to discuss a little bit about systolic failure and diastolic failure, and then we're going to go more specifics into right and left-sided heart failure. So systolic heart failure is the most common cause of heart failure, and it occurs when the heart is weak and enlarged. So if you look over these caused by impaired contractility function, could be related to a previous myocardial infarct, increased afterload related to hypertension, cardiomyopathy or an enlarged heart muscle, and any mechanical abnormalities, any valve disease or issues with the mechanical functions of the heart. The muscle of the left ventricle loses some of its ability to contract or shorten. So in turn, it may not have enough muscle power to pump all of that oxygenated blood and the nutrient-filled blood to the vessels, throughout the body. Diastole is the phase of the heartbeat when the heart muscle relaxes. That should allow the chambers to refill with blood. So diastolic failure is that part of the heart function. It's impaired ability of the ventricles to relax and fill during diastole, resulting in decreased stroke volume and cardiac output. Diastolic failure is characterized by filling pressures due to stiff or non-compliant ventricles and results in venous engorgement in both pulmonary and systemic vascular systems. Diastolic heart failure it could also be referred to as diastolic dysfunction. It refers to the decline in performance of one, usually the left, or it can be both left and right ventricles during that resting phase. It's diagnosed based on the presence of, and then it lists it here, pulmonary congestion, pulmonary hypertension, ventricle hypertrophy, and normal ejection fracture. Some of the causes of this diastolic heart failure include left ventricular hypertrophy, that enlarged muscle. There's a picture actually coming up that will show the difference between dilated ventricles and hypertrophied ventricles. So you can kind of get a visual of that. There's also one in your book, but I don't have the page number. Also aortic stenosis. So if the arteries are tight or prevent proper blood flow, you can also have this diastolic failure. Hypertrophic cardiomyopathy, and again, that enlarged heart leaves the walls stiffened. They don't have that ability to relax and refill during diastole. I skipped over a few slides that talk about the compensatory mechanisms related to heart failure. The most important, I think, that for understanding heart failure, since this is your first introduction to heart failure, I think is the neurohormonal responses. So low cardiac output, so the heart isn't able to supply an adequate amount of blood to the necessary organs, can decrease cerebral perfusion pressure. So I know we talked about vital organs and everyone thinks the heart and the lungs and the liver and the kidneys, and yes, those are all important, but really the brain is very important. So because of that low blood volume and inability to properly perfuse, it can have decrease in cerebral perfusion pressure. So antidiuretic hormone, or ADH, is secreted, and because of that, it causes an increase in water reabsorption in the renal tubules, leading to water retention and increased blood volume. There's a video that I put in Canvas. I hope you guys are able to see it, that kind of puts heart failure, it summarizes it very well. It says what's happening in the heart muscle, how it affects the capillaries of the lungs and of the extremities, and how increased blood volume can occur, and how diuretics help to manage that. So I want you to be familiar with antidiuretic hormone is secreted due to that low cerebral perfusion, which then can lead to increased blood volume. So over time, these compensatory mechanisms, and there's a whole list of them. If you look at the original PowerPoint, you can see it goes into renin-angiotensin and converting angiotensin 1 to angiotensin 2, and there's all kinds of things that I don't think are necessarily applicable to this level of learning. So if you're really interested in that, please read the chapter and go over that in more detail. But for purposes of the lecture and for testing purposes, I just want to talk about these items that I have on the slide. So the compensatory mechanism, neurohormonal responses continued. Over time, a systemic inflammatory response is mounted, which then results in cardiac wasting, muscle myopathy, and fatigue. I think this is very important to have that understanding of how heart failure comes to be. As the an initial injury or initial response to the heart, there's all kinds of compensatory mechanisms that's trying to make up for loss of function in other areas. And over time, this is the wear and tear that's happening and what's happening to the heart. I feel like I covered this a few slides ago, but let's just go over it one more time. So consequences of compensatory mechanism, that dilation that happens. I talked about the dilation and the hypertrophy that happens. So this next slide that we're going to show you is going to show that. So the enlargement of the chambers of the heart that occurs when pressure in the left ventricle is elevated. Initially an adaptive mechanism, eventually this mechanism becomes inadequate and the cardiac output decreases. So you can kind of see that initial dilation to that hypertrophied effect on this next slide. Okay, so again, the initial reaction or compensatory mechanism is that dilated effect, whereas over time it becomes that hypertrophied heart chamber. So you can see the difference between A and B here, A being dilated and B being the hypertrophied. As previously stated, hypertrophy generally follows persistent or chronic dilation. Thus further increases the contract power of the muscle fibers. This will lead to an increase in cardiac output and maintenance of tissue perfusion. Hypertrophy, increase in muscle mass and cardiac wall thickness in response to chronic dilation. And so this would then result in poor contractility, which we've already discussed, higher oxygen needs, and that's just due to the fact that because the muscle of the heart isn't pumping properly, that oxygenated blood isn't perfusing and getting to the tissues. So if we're having pump failure or heart failure, the oxygenation demands will increase. Poor coronary artery circulation and risk for ventricular dysrhythmias. Okay, this is going to be my last slide on the pathophysiology of heart failure. And this is something that's really important to understand, especially as you're caring for patients in acute care settings in relation to heart failure. These lab values and diagnostics are important to understand. So ANP, or atrial natriuretic peptide, is stored within granules in the atria and ventricles. So even minor cardiac muscle stretch can cause release of this peptide into circulation. The B-type natriuretic peptide, or BNP, in contrast, is only a small amount of BNP that's stored within the granules of the ventricles. The release of this BNP is triggered by an increased pressure, especially on the left ventricle. The BNP levels have been shown to be significantly increased with patients in heart failure. And when I say significantly increased, the lab values you could probably look up. I think they're in this chapter, but they say anything over 100 is a potential for heart failure. But I have seen patients admitted where this BNP is in the thousands, 3, 4, 5, 6,000. So the number can get significantly high, and it's an indicator of heart failure and that fluid overload. So it's released in response to increased atrial volume and ventricle pressures. I think we already talked about that. Chronic heart failure leads to depletion of these factors.